Very good afternoon, everyone. In my presentation, I'll be discussing the role of multimodal imaging in a case of scotoma, especially a central scotoma. So, this patient was seen by multiple doctors at our center, and finally he came to me. So, without wasting much time, let's chase this scotoma and then see where it will lead to us. A 55-year-old male patient, a government engineer by profession, he presented to a primary doctor uh, with a chief complaint of a flash of light in his right eye since 1 week. It was a known case of diabetes as well as hypertension from last 10 years. He underwent his radio ablation for his PSVT in 2021. So this was the fundus findings which were noted by the primary physician. His visual acuity was 6/9 in the right eye, and then left eye had a 6/60 vision. So his main complaint was photopsia. When the documentation from the primary physician showed the grossly normal fundus without any much changes except these focal RP changes, especially in the papillomacular bundle area, which was evident on the OCT in the right eye. Left eye had a very diffuse kind of some kind of hypopigmented changes over the posterior pole, and then there is some vascular insult, especially in the superior aspect. I will not discuss the left eye much because the diagnosis was very clear. This patient was made a diagnosis of PVD and then sent home. So left eye, like when we take the past history, so he had a extrafoveal CSR in the left eye. In 2012, he underwent a focal laser for extrafoveal CSR, and then he knows his left eye visual prognosis. So again, like the patient was not happy. Again, he had an increase in the flash of light, especially in the right eye, along with the central scotoma. He came to the primary physician. Again, they examined him. He had a visual acuity of 6/9. Again, the fundus was nothing was there. Like fundus examination didn't show any abnormality. Again, just because he had a central scotoma, and then he was sent for neuro-ophthalmological workup just because of a central scotoma. So our neurology team did every possible investigation with this patient, like including MRI brain, CT angiogram of the neck, CT angiogram of the brain, neuromyelitis optica workup, each and everything, including CSF analysis. Everything was within normal limit. The ophthalmology part, again, like they also did OCT RNFL as well as OCT GCL. So in that condition, like only the GCL part showed some kind of swelling in the temporal aspect of the GCL part. So again, like finally he came to me using all his influences and all. Like on 17th February in the evening, he came to me with the same chief complaints of flash of light increase along with the fluorescence, again central scotoma. I examined him thoroughly, but even I didn't find any findings. Even I made a diagnosis of PVD, and then I sent home. So once, just about like I was about to leave the clinic, again he came to me with a field defect, and then he was just opened a piece of paper and then showed me the field defects. When we saw his field defects, like I said, like just get the visual fields and then we'll see you tomorrow. Again, like when we saw the visual field, his fields were grossly depressed. So when I saw this patient and then I ordered a OCT, I was surprised to see the outer part of the retina show some kind of outer retinal changes, especially in the external limiting membrane, ellipsoid zone, and then the interdistortion zone. There is a degeneration in the outer aspect of the retina, especially in the papillomacular bundle. I just compared the 19th January and then 9th February, 2 weeks apart OCT. In that condition also, it was quite evident that the outer part of the retina showed some kind of degeneration. The ultra wide field fundus photo of the right eye didn't show much abnormality. The angiogram did not show any abnormality except some kind of window defect, especially in the peripapillary area. So the left eye had a BR vivo insult and then extrafoveal changes. The OCT showed like within 1 month it shows a very gross degeneration, especially in the outer aspect of the retina when compared to 19 January and from the up to the 24th February. The ultra wide field antofluorescence showed a very characteristic outer very characteristic peripapillary hyperreflective hyperautofluorescent lesion, especially in the right eye. So the top con did not show any abnormality, but the ultra wide field autofluorescence showed this abnormality. So based on these things, like we made a diagnosis, we had a differential diagnosis of acute syphilitic posterior placoid chorioretinopathy and then acute zonal outer retinopathy. But when we did the TPH and VDRL, both were negative. It was repeated again. Then that time also it was negative. So when we were going through the literature, and then we only published some 3-4 years back a similar case of acute zonal outer retinal necrosis, where the characteristic findings were missing. So again, like I was searching in the literature, and then I was came to some terminology, something called acute annular outer retinopathy. So till now, only 18 cases were reported where there are like they showed some regeneration of the outer retinal changes. Finally, we made a diagnosis of acute annular outer retinopathy. So and then because of patient had a CSR, we didn't give steroids, and then we directly put him on immunosuppression, local as well as systemic, because systemic is going to take time to act. So hence we managed this patient with the Delphapo 2 intravitreal dose of methotrexate. After 2 intravitreal of methotrexate, his symptoms were relieved. His autofluorescent lesion is drastically reduced, and his visual acuity was 6/9. Again, like the OCT showed marked regeneration of the outer retinal layers, especially the external limiting membrane, ellipsoid zone, and then the interdigitation zone. And his visual fields were markedly improved. Like he was like almost having no symptoms right now. He was still on azathioprine 150 mg. Thank you.